Hi there, everyone. I'm Dr. Jonathan Rajan, and I work at Salford Royal Foundation Trust, and I've been asked by Vicky Lucas on behalf of the AGSD to talk to you today about Pompe's disease, and specifically the pain medicine perspective. This is a talk that I've been lucky enough to give to some of you in person before, and I'm only sorry that I can't do that today. It's my privilege to talk to you from a pain point of view, and I hope that you find this talk somewhat informative and also interesting. So, pain in Pompe's disease for me is something that I see at Salford Royal, and I'm very privileged to work with the Metabolic Medicine Department here, which is one of the largest in the country, working in collaboration not just with Pompe's disease, but a range of other metabolic and lysosomal storage disorder conditions. So this talk is really going to focus on pain in Pompe's, and I'm interested to see how you experience it, what the challenges of the condition are for you. I will talk to you about medications, their roles and their limitations within Pompe, what pain service personnel we're lucky enough to have working with us in the pain centre, what we offer, access to the pain service and the referral and treatment process, as well as the future goals that we have as a service. So I'm not going to talk too much about the pathophysiology of Pompe disease, but suffice to say that the lack of acid alpha glucosidase and the impacts upon that in terms of glycogen storage are mainly discussed within terms of the respiratory effects and the effects on cardiac muscle. But from a pain point of view, I think it's important that we understand that the knock-on effects that has, particularly on skeletal muscle and on the musculoskeletal system as a whole, and the effect that leads to in terms of pain, but also in terms of patient function. It's also clear that depending on the level of deficiency of acid alpha glucosidase, there is a spectrum of disease going from the infantile form into the form that tends to affect adults, and a wide spectrum in terms of pain and also in terms of function. So I'm not going to focus too much on the infantile form of the disease, but really on the pain that adults experience in terms of proximal muscle weakness being common, the tremendous impacts that can have on daily living. We know there's a variable prognosis, and that will depend on treatment, so enzyme replacement therapy, and the age and expedited nature of diagnoses. So if we can diagnose these patients quicker, if we can diagnose you quicker, then we can hopefully prevent some of the deterioration in muscle strength, in muscle atrophy, and therefore improve function. There's not a clear evidence base around pain and Pompe's disease, and we are dealing not only with pain, but also on the effects of the disease on the heart, on the chest and the respiratory system, the liver, peripheral nerves, and dealing with other syndromes like sleep disordered breathing, all of which have an impact on the kinds of rehabilitation that we can do for patients, the kinds of patient groups that are suitable for various medications. And so really when treating pain in Pompe's disease, it's important to bear in mind that you can have an impact on pain, but you may also adversely affect some of the other organ systems that are affected by Pompe's disease. And in turn, those organ systems that are affected in Pompe's disease may have a direct impact on the quality and the nature of the rehabilitative work that you can do in patients who've had long-standing pain because of the disease. So moving on to the physiology of pain perception. So many of you will be familiar with this. Pain perception is really dependent on the initial process of transduction. So taking a stimulus, converting that into an electrical signal which is transmitted and maybe modulated at various points in the brain and the spinal cord, before you eventually perceive that in the brain, and that stimulus, that painful stimulus, is then interpreted, be that in a positive way or in a threatening way. And this then impacts directly upon behavior and upon organ systems. So that may be in terms of heart rate, in terms of the rate of breathing, sweating, feelings of anxiety or distress around pain, depending on how the patient's perception is then moved into an interpretative phase, will depend on how their behavior around pain and therefore their function changes. That process is tremendously complex and is very simply outlined in this diagram, going from what's described in this diagram as injury, but can be taken to be the effects of the disease in terms of glycogen storage, and how that can affect peripheral nerves and the central nervous system, and then leads to alterations in the way that pain is perceived in the central nervous system and in the brain, and thus affecting behavior. So we know that the effects of Pompe in terms of glycogen storage can affect not only the heart, not only respiratory muscle, but also peripheral nerves, leading to an increase in the range of receptors and an increase in the receptive field, and also a reduction in the threshold, or the trigger point, if you like, at which point these nerves may fire. In other words, stimuli that may not originally have been painful may become a painful source of a painful stimulus, and the threshold at which a stimulus needs to reach before it becomes painful is effectively lowered. So things that weren't painful before can become painful over time. And that process of peripheral sensitization isn't specific to Pompe's, but is something that can occur with repeated painful input in a variety of conditions. In a similar way, central sensitization can occur such that the central nervous system has a lower threshold at which it fires, so to speak, and a wider range of inputs will lead to transmission of pain to the higher centers within the brain. And this can be summarized within this diagram, whereby one has input at the spinal cord level. There may be changes in the way that this is modulated before it is then transferred or processed within the brain, and I'll come on to that in a short while. You can see from this diagram that there are the pink descending tracks as well as the green ascending tracks, and so the balance between painful input that goes to the brain can be offset somewhat by descending input, or often known as descending inhibition, which can block out painful stimuli. And this occurs on a day-to-day basis, both in patients and in patients without disease, and modulating that system either through drugs, medications, or through rehabilitative talking therapies is one route to combating pain, both in Pompe's and in other diseases. So we can see here another simplified diagram of the transduction, transmission, modulation, and perception of pain. And one can see that there are various different targets, both peripherally, at a spinal level, and also at a brain level. And this is a very simplistic diagram of where potentially different agents might act either on the ascending pathway which transmits pain to the brain, or the descending modulative or descending inhibitory pathway which stops pain. And these are some of the mechanisms that we try to engage with within a pharmacological approach to managing pain. I wanted to bring this up as a way of trying to explain that the way that pain is perceived traditionally would involve the sensory cortex. So looking at the way that that part of the brain is triggered with a painful stimulus. But there are also in chronic pain, as opposed to perhaps in an acute pain setting, more involvement of what we call the medial pain pathway. And that pathway involves different parts of the thalamus, the amygdala, the hippocampus, those areas of the brain which can form memory and alter a patient's understanding and perception of pain as perhaps more threatening, or perhaps triggering previous memories of pain and therefore altering behavior. So we can see that pain, the way that it's transduced from a stimulus until it becomes an actual painful experience, is a tremendously complicated process. It's a process that involves the peripheral nerves, the central nervous system, and the brain. And that process can be is a process which isn't hardwired. It's something that's changing all the time throughout the course of disease. So early in the phase of disease, the central nervous system and its response to pain can be quite different to later in the disease, and therefore the patient's experience of pain can be different. Clearly, we are not able to rein back the changes that occur over time, and so it's really a case of trying to plug into that system somehow, either pharmacologically or with talking therapies, to change the way it works. So we may be talking about changing the actual injury, if you like, or the actual triggering factor, and that might be via enzyme replacement therapy, although there's no clear evidence that definitely changes pain perception and pain experience in the longer term. It may be through altering chemical pathways via medications. It may be through altering the patient's mindset and, around pain. So their coping mechanisms, their distraction mechanisms around pain, and it may be through changing the context and their understanding of pain and what that means for their body. And it might also be focusing on the knock-on consequences that occur as a result of pain, be that anxiety, depression, or worry about the future. By doing so, we may not be able to change the pain itself, but we might be able to change the pain experience. And that's really where a more holistic approach to pain and Pompe's disease comes. I will move on to talk about some of the more biomechanical or medical approaches, but I think it's really fundamental for our approach in pain medicine that pain in Pompe's and all the lysosomal storage disorders is managed not just biomedically and biomechanically, but also from a more holistic point of view. So we've been lucky enough to set up what is, I think, the first joint pain and metabolic clinic in the country, where we are able to see patients with our metabolic colleagues together and form joint management plans around managing their pain. This reduces waiting times, it enables patients not to have to attend repeated appointments, and it promotes joint learning and working, bringing expertise together. So we do have a joint pain and metabolic clinic which runs at least twice a year at Salford with my metabolic colleagues, including Dr. Carolina Stepnier. So some of the pain challenges that we face in clinic is there's a lack of recognition really across the spectrum within healthcare professions, probably outside of metabolic medicine and tertiary neurology around Pompe's. Pain clearly can affect multiple domains, so it may not just be muscle pain that the patient is facing. It may be that pain affects them in terms of their sleep. It may be that pain is worsened because of nighttime hypoventilation. It may be because pain is worsened because of their exercise tolerance is reduced, increasing their suffering. Pain in Pompe's affects a wide range of different age groups, all with their own challenges. And of course, it's a multi-system disease, so it doesn't just affect the heart or the kidneys or the liver, but many different organ systems. Diagnoses may be delayed or confused with other diseases, and this can impact upon treatment and the patient's confidence in the healthcare system. So in terms of medications, there's a massive gamut of medications that we can use. The problem with medications for treating chronic pain is that generally, and this includes the lysosomal storage disorders, it includes Pompe's disease, they're probably not particularly effective. So we're probably talking about helping about around 1 in 3 patients, around 30%. Clearly, things like morphine and oxycodone may have a role to play, but their long-term benefit is doubted, and there are a range of sequelae, a range of consequences that could be deleterious in a Pompe's patient. So Pompe's disease patients often have, for instance, nighttime hypoventilation. They may have a reduction in respiratory capacity, and the respiratory depression from opioids means that they have to be used with great care. In addition to that, their metabolism may be impaired in advanced stages of disease, so that also needs to be something that is considered. Anti-inflammatory drugs may have a role, but in the longer term they tend to have adverse consequences in terms of heart health, in terms of kidney health, and in terms of stomach health. And so in the long term they may not be a very effective or safe method of treating pain in patients who may already have impaired kidneys and may already have impaired cardiac muscle. Just wanted to mention briefly about our philosophy with regard to opioids. We don't tend to prescribe opioids in high doses. The trials are usually quite short, and there has to be clear evidence of effect. And the reason for that is that opioids don't tend to work well in the long term for chronic pain. They're very good at treating acute pain, but not so much long-term chronic pain. They have a range of side effects, including impaired ability to fight infection, impaired hormonal levels, and an increased risk of falls, fractures, and bone thinning. So our approach to opioids is to minimize these risks and to monitor for adverse consequences. This slide shows a variety of neuropathic or nerve type drugs which we think may be more appropriate to use in long-term chronic pain and Pompe's disease. The tricyclic antidepressants are used not at antidepressant doses, but at lower doses to help with pain, sometimes sleep and function, but again have to be used with great caution in patients with hypertrophic cardiomyopathy and patients who may already be struggling with nighttime hypoventilation, as tricyclic antidepressants tend to cause sedation. But there are a range of other medications which may be useful to some degree in helping input into that complex sensitized central nervous system to change and modulate the way that pain is processed. I would say that most commonly we would use agents such as the gabapentinoids, so gabapentin or pregabalin, sometimes tricyclic antidepressants like amitriptyline, or agents such as duloxetine. They all have different side effect profiles. They can all cause, to some degree, sedation, most commonly with the tricyclic antidepressants and the gabapentinoids. And the gabapentinoids themselves may lead to weight gain, which can be a problem, particularly if patients are having issues with skeletal muscle atrophy. We use a biopsychosocial model for pain. So the pain that is experienced in Pompe's is genuine, it is experienced by the patient, but we might be able to modulate how it is felt and their behavior. It's clear that disability is not predicted in many diseases, including Pompe's, by pain alone, and that other factors influence this. And so targeting these other biological and non-biological factors may improve patients' quality of life. So, for instance, by trying to improve sleep, we may improve quality of life despite the fact that pain stays the same. We've talked about some of the pharmacological agents that we use, be that tricyclic antidepressants, opioids, or other neuropathic agents, and I think they all have a role to play, used judiciously and carefully selected according to the stage of disease that the patient is in and the side effects that they suffer as a result of their organ system dysfunction. Probably most commonly and most usefully used drugs are the neuropathic agents rather than opioids and rather than anti-inflammatories. We also have a range of musculoskeletal techniques, so nerve root blocks shown in the bottom right, or joint injections, as many patients with Pompe's disease suffer from scoliosis as their disease progresses. They may suffer from advanced degenerative change in the musculoskeletal system, secondary to muscle atrophy and wastage, and their cardiac conditions and respiratory condition as it advances may prevent significant exercise, leading to a vicious cycle of further atrophy. And so these techniques, these musculoskeletal injections and nerve root blocks may provide some help for some patients and also reduce the need for medication-based therapies. More advanced techniques like radiofrequency ablation are also available and can be used for some patients with success. This may be, for instance, to help with hip pain, knee pain, or sometimes lumbar or thoracic pain. So we're lucky enough to work with a range of different personnel within the pain service, as well as the medical professionals. We have a team of expert pain psychologists and pain physiotherapists. So the role of the psychologist, who I should stress is not a psychiatrist and is very different, is to use talking therapies, cognitive behavioral therapy skills to help the patients understand the barriers to their progress in terms of improving their quality of life and potentially function, to educate them around the stress response that occurs with pain and how we can modulate that in chronic pain, because pain itself is not always a sign of ongoing damage. To teach stress management techniques and to help with things like confidence, sleep, and the effects of pain on communication and behavior. So the clinical psychologist will often look at harm beliefs, distress caused by past medical interventions, mental health, the patient's goals and how to achieve those in smaller steps, and a focus on rehabilitation and an improvement in function. The pain physiotherapist will look at the fitness and confidence with exercise, help pace up exercise if possible, and the use of aids and appliances that might help a patient with advanced Pompe's disease in improving their function and their quality of life going forward. A physiotherapist will look at things like the previous pain history, previous interventions, aids and adaptations, exercise tolerance, and their experience of exercise therapy or physiotherapy in the past, which is often quite negative, and how we can work around that to help the patient. So we've talked today about the pathophysiology of Pompe's very briefly, the medical therapies that we can use, and the drug therapies that we can use to interact with a very complex pain system that gets affected not only in Pompe's disease but in other lysosomal storage disorders. We've talked about peripheral sensitization, the changes that occur centrally within the brain and the spinal cord, and how the drugs can affect that to a small degree, but probably the great benefit of Pain Clinic is then to work with that system to modulate it and to change it so that patients get a greater quality of life and improved function, even if pain continues and potentially worsens. In future, we'd like to have greater collaboration with our metabolic colleagues, further joint clinics, and expedited referrals for our Pompe's and other metabolic patients, with greater case conferences and early referral to improve our outcomes. And hopefully going forward, we will have some expert patients from the Pompe's cohort and from other cohorts with lysosomal storage disorders. Thank you for your time. I hope this has been of some interest to you, and I'd be happy to take any questions or correspondence, and I'm sure that Vicky or one of the team can give you details of how to do that. Thanks very much.